So, on behalf of Andreas Ulrich and my person, we thank the program committee for this wonderful opportunity to discuss Women Health Summit session and to discuss women health in the COVID-19 era and to look on challenges and opportunities. And I'm Jared Ziuri, the director of the Department of Gynecology and Deputy Director of the Charité Comprehensive Cancer Center. And I'm really, really proud to host with my friend and colleague, Andreas Ulrich, this great thing, because I think we are in the same road that women health is maybe one of the critical quality indicator for every healthcare system. And that's the reason why we want to specifically address this issue and to look on the different perspectives from the clinical routine, from the industry, from the big institutions. And I'm really proud that we are running in this outstanding dialogue. Andreas.
Good morning, ladies and gentlemen. Good morning, speakers. Welcome to this really exciting session. I'm Andreas Ulrich. I'm a former WHO staff, and I've joined the Charité. I have the privilege to be hosted at Charité as a visiting scientist and advisor on global health matters. I'm based now in Geneva. I would love to be in Berlin with all you, but now I'm here with Princess Simelila and Shannon Hader in Geneva. And I would like to give a little bit an overview of how we structure these 1.5 hours together and with an audience, with a virtual audience, and how we make it really interactive. First of all, some housekeeping. There's a button on the Zoom function, which is called F&A in German or Q&A in English, where all the participants from outside can write questions to the audience, to the speakers and to the co-chairs. So this is the only way how we can bring in the public. We have 3 sections. We were supposed to answer 3 questions. The women health agenda has got a major impact through the COVID crisis. And we say that a recent Lancet article is titled COVID-19 has a devastating effect on women girls. So the first question will be how your organization you are representing and are your women health policies have been affected. We will then go to a problem solution opportunities through the COVID and goes to the third question where we say, how can we move forward with the women health agenda with the lessons learned from this crisis? Can we take something from the crisis to the future? So I would like to introduce Princess Nothemba Simelila. She is the special advisor to the Director General of WHO for the women cancer strategies of WHO. She will now have a short statement about how COVID-19 has affected her work on women health, on women cancer globally. Princess Simelila, the floor is yours.
Thank you, Andreas, and thanks to Professor Ziuri and my fellow panelists, and welcome to all the participants. I think it's now common knowledge that women and girls, especially those who are in developing poor countries, who are in marginalized communities, are the ones that are already suffering the impact of COVID-19. First and foremost, I think the impact of this pandemic has exposed things that we even did not know, that health systems across the globe, whether you are in a developed or a developing country, were not ready for such a pandemic, although we have been preparing ourselves for something like this, we haven't done that. Women have suffered in that countries during the lockdown made access to health services impossible, or there were just none. So we know, for instance, that a number of indicators are not looking good. Firstly, women did not access antenatal care services. Some of them in very dire straits were not able to deliver in facilities. We know that there were limits to access to any sexual and reproductive health commodity. So we are expecting millions. I think UNFPA estimates about 7 million unintended pregnancies, which is a disaster for countries post the COVID era, because you now have all these unplanned children, unplanned babies who are going to be placing a strain on both their mothers and the system. We know also that women with pre-cancer did not get access to screening services, particularly for cervical cancer, even for breast cancer, and that those who were advanced, some of them actually did not receive the surgical care they needed because of this uh, immediate and unprecedented and, you know, very big challenge that countries suddenly faced. So everything that we have tried to do, or that we had achieved prior to this pandemic, is likely to be reversed. The gains that we had made before we got into the SDGs are going to be badly reversed. And the challenge is not just now, the after effects in the next 2 to 3 years. It's only then that we will be able to really count the impact. Even beyond health, we know that women are suffering already. You know, women are engaged in the informal workforce, for instance, and a majority of those jobs disappeared. They are carrying a lot of the unpaid work, and that is already a triple burden for women. And they are also in sectors who are likely to be paying them less and who would be the first to be released from those jobs once economies and countries realize the economic impact of this pandemic. So globally and generally, women are really at the bottom end of this, they and their children. And unfortunately, being 70% of the workforce, it means they were directly in the eye of the storm when the countries got hit by COVID. So they have suffered as providers, they're suffering as women, they're suffering as individuals in their own communities, and they will continue to feel the after effects of this pandemic for a very, very long time. And that begs the question, how are we as institutions going to respond, and what have we done to address this? And I can mention a few things that we have done as WHO. First and foremost, we noticed that countries were reporting, but they were not disaggregating data by sex. So we didn't know what was happening with this pandemic. We knew very quickly what was the cause of this, although we still have not found the intermediary hosts for this. But only now that we are getting more and more data, disaggregated reports, we can see that it is men who seem to be worse affected, but we haven't really found the root of the protective effect. What is causing women to be less impacted by COVID? And even if we find that and we can amplify it, we still know that at the end of the day, women are resilient and they will carry the morbidity of COVID much longer in their lives if they survive at the death aspect of it, which is also a problem. We have also been providing a lot of guidance around many issues. You know, how should countries maintain essential health services? How should countries prioritize access to safe sexual and reproductive health services? How should countries be prioritizing those diseases that we know, if they are not attended now, will really lead to preventable deaths for women? And then ensuring that the health work front force, uh, we have enough PPE for everybody, but especially for women who tend to be in the services that, the supporting services such as cleaning, such as providing food for the patients and things like that, that they are treated in the same way as the experts in the IC room are treated, given proper protective equipment for the work they are doing. There are many other things that WHO has done, not on our own, but working with all the partners, with the colleagues on this panel, and many other professionals across the globe to sustain this. And we're still trying to see how we can truly, truly build systems that are truly better, not just the rhetoric. What should the health system look like post-COVID in a way that a woman can say, yes, I feel completely attended to and responded to by this health system? And some of these issues, I think, will come up in this conversation. Thank you.
Andreas, I think you're muted.
I'm so sorry. Now I would like to hand over to Shannon Hayder from UNAIDS. She's the Assistant Director, Secretary General, Deputy Executive Director of Programs of, and for everybody, the joint United Nations Program on HIV/AIDS. Shannon, over to you. What have you faced in these terrible times from the gender perspective in dealing with HIV/AIDS policies of UNAIDS?
Yes.
Over to you, please.
Sure. Thank you so much to the organizers for this session. I don't think we could have had a more critical session at this time. So it's a pleasure to be here with my co-panelists. Very exciting. Yeah, so what are the lessons we're seeing and what are we dealing with in that intersection between COVID and women and HIV? So building on, I think, what Nono mentioned and going a little bit deeper, we are seeing not only are women affected in distinct ways under COVID, but some women are more severely affected than others. Gender diverse people, sex workers, women who use drugs, migrant and incarcerated women have specific needs and specific challenges under COVID. Some women have greater urgency for how we need to respond and how timely we need to respond, whether it's pregnant women living with HIV or children living with HIV. For example, women sex workers nearly always considered to be in the informal economy. And in many cases, that means they have no access to the social protection systems that are being mobilized under COVID. So they're not only out of work, but they have no money, no food, no rent, no medicine, reduced access to condoms or health services, and importantly, increased fear of harassment or violation. And we've seen that in countries from Ecuador and El Salvador to Kenya and Senegal. Women living with HIV and children living with HIV, women living with HIV who are pregnant. Now, fortunately, about 85% of them worldwide are already on HIV treatment, which is great. But we need to make sure during these critical times of pregnancy and breastfeeding, even more so, that there's not a window of interruption. And that for women who aren't already diagnosed or aren't already on services, getting them during this time and not just letting a pregnancy go by without these critical services. Similarly, children living with HIV, only about half of all children living with HIV are currently on HIV treatment before COVID. Again, time ticking the clock. There is a greater urgency to find children who are untreated and make sure we don't have excess deaths and excess missed opportunities. Second, I think we've seen that COVID has further revealed deep-rooted stigma and discrimination. Traditionally stigmatized populations are further ostracized and even denied basic rights and services during this time. For example, governments have used lockdowns to apply restrictions and crack down for un-COVID related reasons, I would say, on trans people in many countries, on lesbian women, on women who use drugs. Third, though, we have seen that certainly vital HIV, TB, and harm reduction services for women have been disrupted. However, I guess the silver lining is we've seen that these disruptions have been mitigated in countries that have intense engagement and involvement of communities, of community-led organizations, of people affected, by people affected, including organizations of women affected, for women affected. We have seen community-led organizations delivering essential supplies and HIV medicines. We've had them help in surveillance efforts. We've seen them challenge misinformation about COVID and ensure that vulnerable populations aren't excluded from COVID services. In Nigeria, Sierra Leone, across West and Central Africa, we've seen these community-based organizations providing vital COVID-19 awareness and support, often without funding at this time. And then I think finally, we have seen that innovative service models that emphasize self-care, reduce physical contact have worked well for a number of women. Self-testing for HIV that can ensure continuity of HIV services for higher risk populations have been expanded under COVID much more rapidly than they were before COVID, and that's not a bad thing. We've seen self-testing expand in Burundi, in Eswatini, in Guatemala, and Myanmar. And we've seen telephone or other electronic or distant supports used to reach population groups and allow women and others to stay engaged with their own care through new technologies. So there are a lot of challenges. Women are affected unequally, but really that solution set, that agility and creative, empowering solution set led by women for women has where we've seen the critical solutions lie.
Shalit, over to you to introduce the next.
Thank you very much for this great statement, and I'm happy and proud to call Anja Langebucher from the Bill and Melinda Gates Foundation and the head of the European office, and to listen to your statement, please.
Thank you very much. Thanks to all the fellow panelists and to Andreas and Jelly. Thank you very much for hosting this important panel as part of the World Health Summit. I think both of my pre-speakers have already touched upon very, very important pieces of the situation. And I think, as Princess Simalela was saying, I mean, it's common knowledge by now that women are disproportionately affected in many, many ways. And of course, one of the things that is the most obvious one is how their access to health services has been restricted by the COVID crisis and has aggravated some of the situations that we've seen already before. Of course, at the bottom and at the core of the work of the foundation are programs around MNCH, maternal neonatal child health, but also family planning. Both of these are obviously at the center of some of the programs that are now adversely affected. We even have even higher numbers than we've heard before for unplanned pregnancies, which are really scary to hear, because we are very much afraid that up to almost 50 million people may not have access to contraceptives for previously well-functioning family planning programs, and that will lead to a large number of unplanned pregnancies that, as we were hearing, is obviously very concerning. Even also just reinforcing that the WHO survey that was done, which really confirmed that in a huge number of countries, women will not have access to delivery units in the way in normal times this would have been the case. And here we are really seeing that women are put at risk because their right in order to have sexual reproductive rights being treated as an essential right and need for them is really put at risk here. So this is something that we're of course also very concerned about at the foundation. Some of the norms that are more playing into the situation that women are adversely affected with COVID are, I think, also important to point out. I mean, because of studies that we've run previously, we're seeing, for example, that women, because of the tradition, because of the setup of families, are usually the first to nourish their families first and not themselves. So being probably the first victims of malnutrition malnutrition. We've also touched upon the large amount of domestic work that we are seeing that is now falling again on women's shoulders, and of course this time poverty, as we're referring to it, which really is a testament to all of the unpaid work that women need to take upon themselves during such a crisis. Lockdowns and situations where domestic challenges are really increasing even more than they would have under normal circumstances, where we also see a dramatic uptake in domestic violence and in cases that are threatening and really concerning for women's health. Some of the economic stimuli programs that we are seeing that are really helping, of course, a lot of the economies, and we are very much grateful of the trillions of dollars that are being poured into economy, but also, as we were hearing before, very often that doesn't actually end up in the hands of women because they may not have access to digital tools, because, as we were hearing, they're very often working in sectors that is the informal economy, in traditional sectors such as food delivery, shop assistants, restaurants, street workers, where these type of subsidies are much less obvious to actually hit them. We've seen some encouraging programs with direct cash transfers, for example, in India, where it was really seen that women were reached in a very effective way. But that's the kind of experiences that we really need to build onto even more. One of the other very concerning things is, of course, schooling. And as we do see as schools shut down, we do see that especially girls may not re-enter, may not go back to school, which again will have long-term effects that are going to be incredibly difficult for them to actually catch up on. Coming back to maybe also the question on how can we make sure that we are learning from this crisis, and as we're entering, which feels like an eternity away still, to be fair, but as we are entering as we're referring to the build back better phase, when some of these really dramatic situations may be behind us, what is going to be incredibly important is that women's health will be addressed as a central part of building up health systems. And so I think from the foundation perspective, we're very much focused on how can we put, a gender lens really at the heart of building these programs. And this means, for example, putting women in leadership positions where they are helping to design these programs and think through from the beginning, what are the experiences, what are the needs, and what are the special situations that women need to be built into the health systems work as this is being built up. And this can be very simple things, such as scheduling. It is not possible that women can only come to hospitals at the block schedules for very certain services to access them. That is not a situation that is neither sustainable nor effective, nor promising to work going forward. So as we look into the future, I think we can build on some of these very positive experiences that we've also heard from Shannon, but hopefully also just really embrace how different some of the needs are that women need to be addressed to in the phase that we're hopefully entering soon. Thank you.
Yeah, Anja, thank you very much for this really valuable comments, and I'm happy to invite Theresa Graham, the head of Roche Global Product Strategy, to give her perspective, please.
Great. Thank you again to the co-chairs, to my panelists, and to the World Health Summit for the opportunity to be a part of this incredibly important discussion. I am increasingly concerned that the real legacy of COVID-19 is going to be the NCD crisis that it leaves behind. And I think we all are going to have a really important role to play to make sure that we can do as much as we can for women's health going forward. Even in our most mature health systems, primary care visits are down by 50%. In the UK alone, we saw that 1 million women didn't get their annual breast cancer screenings. And these are in places that should theoretically be the best able to handle a crisis of this sort. And so when we think about the effects that this is going to have on women around the world, it's going to be the next crisis that we have to deal with when hopefully we have more solutions for COVID-19. I am really encouraged by the amount of alignment that we have in the problems that we see. And it gives me great hope that working together in different ways we'll be able to make meaningful progress. I think that the other thing that COVID-19 has put in really stark effect is that there are systemic gender biases in our healthcare systems around the world. And we have to be thinking about this in a really different way if we're going to be able to make progress for women going forward. I mean, it would be unsurprising to any of you that as Roche, we've been very involved in cancer screening programs, and we've had a lot of cancer programs that have happened around the world. But this year, for the first time, we actually put together a dedicated position within Roche to work across both our pharmaceutical and diagnostics capacities to actually look at what we can do for women's health in a consolidated fashion, looking and working with health systems directly to think about how we test differently, how we screen differently, how we think about bringing different medications to women earlier when they can actually do more good. But this is a large and it's a complex problem. And I love, Anya, what you said. Policymakers in particular are going to have to think differently about women when we exit the COVID-19 crisis. And the conversations I think that we're having right now and the bonds that we're forging right now about the importance of these issues are going to be really critical in helping us drive a very different kind of policy agenda when hopefully we get to a different place. So I'm really thrilled to be here today because I'm already hearing so many similarities and ways that make me encouraged that we could actually make this look different in several years' time.
Thank you.
Now, Jalit will introduce question 2.
Yes, so I think it's really important that we look back about the role of women health and even the service and intervention we did before the pandemic, and even to think how is the situation now, and maybe we find in one of the next steps even some solutions how to bring all the activities together. But the question is, have there been any new models of service delivery in interagency cooperation and financing which can be maybe translated to upscaling women healthcare service? Can I start this dialogue and ask you, Princess Similela, and again, we are so proud that you support this panel. What is your answer to this, I know, very challenging question?
Sure, it's a very challenging question, but I think with the other panelists, we can put our heads together to think about what we do individually in our agencies and what we can put together. I think with my colleague Shannon from UNAIDS, there's a lot that we are doing. You know, just as an example of the work that we are doing also with yourselves and Andreas on the cervical cancer piece, the ability to self-collect samples for testing is another, it's an initiative that's been there, but I think we can push it through now because it's been shown in pilot studies in different parts of the continent in Africa that women have no concerns. Those that do, when provided counseling, can actually do this on their own. The HIV community and that field has advanced, you know, in terms of delivery of medication. We're now moving into injectable, long-acting injectable antiretrovirals. And I think the point that Theresa made about what should we be talking about now that should inform this building back better. My fear is that the people who started the conversation around building back better may not be necessarily engaging with the end users at this point in time. And that's where we've always gone wrong. with most of the things that we do, is that we design things here at the 300,000 feet level, and we don't talk to the people who are right there on the ground to say, okay, now we're trying to rebuild this. How should it look? And what must it do in your community for it to work? So I think with this COVID pandemic, the things that we can take forward that have been positive, I think for me, is really recognizing the centrality or the importance of health to development. I know, people are averse to what they call health imperialism, but countries have seen now that without a healthy population, your economy is out the window. So governments must really stop shying away from investing in health. That's an investment. And I think all of us must push for that. The second thing I think is technology and innovation. I mean, the speed with which countries were able to set up the laboratory platforms, get the diagnostic tests out, supported obviously by many of us around the table, other UN agencies, other humanitarian agencies, is another example. And I'm already hearing people on the ground saying, oh, if there's a crisis, the world can do this. Why is the world not doing this anyway for diseases that have continued to decimate millions of people? So innovation, speed, alignment, and really to be much closer to the ground than what we are. And this is what I'd love to maybe have a conversation also with my fellow panelists about how can we really feel the presence of our own institutions at the ground level and not be shy of the fact that actually on the ground, we may be a little bit irrelevant because we don't have big footprints. But how do we make the footprints that are there, which has the footprints of the nationals, much stronger than what they are already? So those are some of the things. And public-private partnerships, how can we get governments to understand that the private sector is not necessarily the beast here? We can find win-win social solutions for countries in the health space and for women particularly. Decentralizing healthcare for women to the smallest shop in a village would be the best thing to do. And governments can only do that if they work with entrepreneurs, innovators, and young people who are great thinkers about how to do things. So these are some of the things that I think we can do better. If we can write less papers as the UN agencies and do more at the country level, I think we are on a good starting point. Thanks, Jerry.
Thank you very much. And Shannon, what is your comment, and maybe even highlight the challenge of communication between all the caregivers?
Yeah, I think we have seen some good examples and some real successes, and even our big, huge UN agencies coming together in new ways to emphasize certain communications or guidelines and line those up with funding opportunities, but also to partner in new ways to rapidly respond to the most urgent issues that are popping up from the ground. So on that sort of realm of more joined up guidance linked to funding opportunities, one of the things that the Secretary General put forward fairly early on was a framework for the immediate socio and economic response to COVID. So recognizing, yes, COVID is a health disease, but like HIV, not only about health, it's about these other supports that people need to absolutely participate in the COVID response and stay safe. And so under this SG's framework for the immediate socioeconomic response, a couple of things we were able to get a little bit more into the mainstream that build actually a lot on what Nono has been talking about. First, UNAIDS worked with UN Habitat to ensure that there was a pillar there for community resiliency that actually, says, and community-led responses. So listening to what people want on the ground, making sure they're part of the governance and decision-making, making sure they're part of services, making sure they're part of monitoring, That should be seen as part and parcel of a resilient infrastructure, not an add-on, not an afterthought. You know, the Interagency Network on Gender Equality and Women that UNAIDS is a member of developed a gender guidance for UN country teams as part of that framework, and a COVID-19 gender response tracker to be able to say, and by the way, no matter who you are with the UN working with countries, don't overlook what women need. Don't think you're doing okay if you're not actually looking into the details, supporting governments to understand what's happening for women in COVID. You know, other new partnerships, UNAIDS has worked with UNDP, WHO, the O'Neill Institute at Georgetown to launch the COVID Policy Lab, www.covidlawlab.org, to share laws and policies that are rapidly changing for COVID-19 from 194 countries around the world, so that we can help know where states are establishing strong legal frameworks to manage the pandemic that really align with international human rights standards. And then along with ILO and World Food Program, UNAIDS has been part of a call to action on social protection and HIV in the context of COVID, calling upon governments to pay special attention to the needs of vulnerable populations, including those living with HIV and key population in their social protection programs. But also impressive has been the even more rapid response when urgent needs or urgent opportunities arise, because I don't think the UN's always known for their most rapid response. Some examples in West and Central Africa, UNAIDS, World Food Program, UNICEF, ILO, we've successfully come together in a pilot that joins up a social protection approach with cash transfers to people living with HIV and key populations in Burkina Faso, Cameroon, Ivory Coast, and Niger to reach these most at-risk populations who are traditionally more hidden and might not be identified in the traditional risk assessment or outreach that the existing social protection institutions use. In Latin America and Caribbean, we've seen financial and technical coordination across agencies be impressive in the way it's responding specifically to refugees, migrants, displaced persons, returnees. And I think maybe on that slightly opportunistic and critically important front, we've seen working across our existing partners and especially WHO with funding partners, implementing partners, country policymakers and implementers to finally put into practice recommendations that have been part of WHO guidelines for years, but never executed. And I'm talking particularly aspects of differentiated service delivery, like multi-month dispensing, to allow clients to access their antiretroviral drugs and other treatments for 3 months or 6 months at a time, decongest clinics that are overwhelmed, reduces pressures on health workers, is better serving for clients and reduces their exposure to 6 people at the health post. And we've even seen finally application of this MMD strategy, not just to HIV treatment, but to TB prevention, to innovative TB treatment modalities, to pre-exposure prophylaxis for key populations, to harm reduction therapies, including opioid substitution therapy for people who use drugs. So these are interventions that are not new. These are partnerships who've been promoting this for a long time, but there hasn't always been that willingness to rapidly act on them on the ground with policymakers and with the demand and drive of community organizations to transform. And we've seen a lot more progress on that than we had for a while. And that's the innovative partnerships really recognizing a need and a chance to not give up, but to finally meet that need and move it forward.
Great.
Thank you very much. And now I would like to hand over to Anja to bring in the Foundation's views and innovation in facing the COVID crisis. Anja, over to you.
Thank you. And yes, lots of very important points, I think, Shannon, and that just raised, and also Princess Simalela. I want to build on some of this innovation piece and also some of the encouraging, actually, collaboration that we've been seeing. I do think that because of the global nature of the crisis, we've also seen, at least partly, a very encouraging multilateral global response. And I think we've also seen an unprecedented collaboration between public and private sector, because we do know that in order to actually globally really fight this pandemic effectively, we will need to have all different actors play together, and that is public sector, private sector, academia and science, civil society organization, philanthropies like ourselves, because we have a huge amount of risk and decisions under uncertainty that we will need to take, and we will need to have a very global effort in order to de-risk some of these decisions that are ahead of us. I think the three key pieces that we've seen multilateral agencies trying to tackle here is, on the one hand side, the huge need to scale up research and development in both therapeutics, diagnostics, and then for the long-term solution, the finding of a vaccine that is effective. And we've seen the other part, the second big pillar that we need to tackle, which is the huge amount of at-risk manufacturing production capacities that we will need to build up, even in the case of a vaccine, taking this as an example, in the absence of knowledge about a successful candidate among the vaccine candidates that we're currently pursuing. And then finally, once we have the manufacturing at-risk capacities actually created, we need to, of course, ensure that whatever tools we're finding are equitably distributed. And a very interesting model that we've ran with one of our partners, IHME, there was a quite astounding and yet also concerning fact that we did see, if we had in a hypothesis situation an effective vaccine that we could be distributing to with 2 billion doses of vaccines, but we would be distributing this to high income countries first and only, we would be averting just about half of the millions of deaths that we could be averting if we ensured equitable access and distribution and allocation of medical tools. So I think this is an important learning, and I want to call out the Access to COVID-19 Tools Accelerator, the ACT-A, which has been put in place by a multilateral and global effort, spearheaded by a lot of governments and the WHO in a leading position, where we really feel that that has been an encouraging sign of the community coming together. It really is, ACT-A, as we call it, is really the only end-to-end solution to accelerate, on the one hand side, what I was saying, the development and research of the new tools across the three pillars of therapeutics, diagnostics, and vaccines, but also the manufacturing, and then makes a big case for the equitable distribution. We have been building on a lot of existing and very good and sound multilateral organizations, such as, of course, under the leadership of the WHO, CEPI, Gavi, the Global Fund, all of these multilateral health organizations that have proven themselves to be really effective players in this challenging environment. A key innovative piece here that I wanted to call out is, I think, the innovative finance mechanisms that we could be really thinking about and pulling in. And also there'll be really an interesting and an important role specifically for women's health. I was just referring to the huge adverse effect if we're not ensuring equitable access from the start, and if we are falling into the risk of high income countries preserving these medical tools first for themselves. We can only imagine that the adverse effect on women specifically is, of course, going to be only aggravated by effects such as these. And I think we've seen the power in multilateral health organizations such as Gavi, for example, what it helps us, how we can pool resources if we pool purchasing powers in support of poorer countries. We have seen how effective these innovative finance tools really can be in order to bring down prices and make sure that some of these tools are accessible for low-income countries from the start, and not with a long delay of many, many months that are going to cost many millions of lives and probably more women's lives. And so I think this key element that we're trying to bridge with the ACT-A accelerator, which is really bringing the research and development findings in an accelerated fashion to product development and then making these products accessible for women and men throughout the world and in poorer countries is through these funding mechanism and financing mechanisms really something essential that we should take as a learning and hopefully also as an encouraging signs of many actors, public, private, scientific community working together effectively. So I think this is something that we can hopefully take up, and we've seen such innovative funding instruments early on play out. We have worked very much with the private sectors. Also good to hear Theresa on this with regards to family planning instruments, where we have worked with volume guarantees and advanced market commitments. We were really able to make these products accessible earlier. And this is at the end of the day what will really count, I think, to make sure we are lessening these aggravating consequences for women. Thank you.
Thank you very much, Anja. And this is a fantastic bridge to Theresa's contribution, public-private partnership, product development, innovation, and make it really happen. This is something where the private sector has a huge role. Over to you, Theresa.
Absolutely. Thank you so much for that. And I just want to touch back on something that Dr. Nono said at the beginning, which is that, we're in a really tough moment in time in our global society, because the reality is we were completely unprepared for the COVID-19 crisis. And as much as we've talked about this being the thing that could really introduce disruption into the world, we didn't take the necessary steps. And so I think we're at a moment in time where we actually see some of this disruption in the future, and we're at a place where we might actually be able to do something about it. And I think where that coming together in public-private partnership becomes really quite critical. Let's make sure that this doesn't happen to us again with the next NCD crisis on the horizon. I think innovation and technical innovation in particular has been one of the things that maybe has been most encouraging out of the COVID-19 crisis. I mean, we are working together as a global scientific community in ways that frankly would have been unthinkable probably 12 months ago. The amount of scientific collaboration, the amount of sharing that we're seeing across countries in terms of treatment paradigms and how we're thinking about our patients and how we're thinking about our healthcare systems, that isn't something that was in our day-to-day world a year ago. At this time, we probably couldn't even have really meaningfully considered it, but we're here. And so I guess my question is, what have we learned that we're going to be able to continue with us going into the future? One of the things I think has been sort of surprising, again, as we think back into the NCD space, is how much we don't really think about women when we think about scientific discovery. Only 43% of clinical trial patients are actually women. And that includes all of the trials that are only for women's diseases. I mean, think about how much biology is left unexplored and how much we don't know about how women, and people of color for that matter, metabolize drugs differently, how their disease manifests in different ways. Like, these are things that we ought to be taking action on today and in a shared way. We haven't talked a lot about the role of technology here, but the role of technology is quite critical to sort of how we think about the world moving forward. I think Shannon mentioned self-testing and the speeding up of that being adopted in places around the world. COVID-19 has the real opportunity to be an accelerator for how we think about the adoption of technology and digital health in our world today. But it is going to require our health systems to think quite differently. Unfortunately, our understanding of the biology of disease and our understanding of how technology can help in the treatment of that disease is outstripping our abilities of our healthcare systems and our public policy systems to actually enable those benefits to be seen. I mean, anyone who has had a relative with cancer, or if you yourself have been touched by cancer, you know that it's not, I do one thing and I do another thing and I do another thing. It's a journey. It's a continuum that we ask patients to go along around the world. And sadly, that continuum of awareness to early diagnosis, to finding the right kind of treatment, to hoping that that treatment is being paid for in your area and that you have access to it, Digital monitoring, things that help you understand, is that treatment working for you? What are the side effects that you're experiencing? Are they impacting your ability to actually contribute to society in different ways? Being able to adjust that, and the holy grail of then being able to aggregate all of that data to actually help us make better treatment decisions going forward. That's not science fiction. That's something that we could do today if our health systems were set up to enable us to enable that to happen. And when I say it's not science fiction, it's, you know, it's something that we're actually working with the Croatian government on right now. They had one of the highest death rates in metastatic cancer, and they decided that as a society that was unacceptable. And so we entered into a collaboration with them where they're now, anyone who is at stage 4 gets a genomic test and gets access to targeted treatments. And then we'll track how that impacts outcomes. Why couldn't we think about doing things like that for women's health in different parts of the world? 75% of women diagnosed with breast cancer in sub-Saharan Africa are diagnosed at stage 4. That's 6% in the US and 5% in Germany. Even if we were just able to think about different kinds of technology to identify high-risk patients, to get them diagnosed and treated faster, that would be a revolutionary advance for women everywhere. And technology can help us do that if we find ways to work together. And, you know, I think, Anya, your last comments are so true. You know, this is a complex puzzle and we all hold a very different piece of the solution. But until we all sit around the same table and start thinking about how to put those pieces together, we're never going to make the kind of sustainable change that we ultimately need to make that's going to make the world look different for our daughters. And that's the place I hope we can get to. Thank you.
Thank you very much, Theresa, for your excellent contribution. And I would like now to transition our session to more interaction among the speakers. And I think there are already many points, common points you have addressed. I'm now, I would like to introduce these question 3 with a little bit of also my own experience as a cancer policy person at WHO. We had this huge problem in agenda setting. Something infectious, global pandemic, of course, creates a tremendous dynamic. But once this is overcome, I'm afraid that NCDs, the non-communicable diseases, the biggest burden of disease on women and men, will be forgotten because we are then focused on pandemics and thinking about other communicable diseases. So I would like to bring this into the panel and say, like, how can we use the momentum now and all the lessons learned to bring this to conditions which are less at the attention of policymakers, but where we have learned that it is possible to develop much faster interventions and to implement them. Who would like to come in first? I like to hand over to you. You are so brilliant that you can manage to dialogue among you. Who would like to first to come in?
Okay, I can start.
Yes, of course. Yeah.
Okay.
Please then make the ball running. Yeah.
Okay. All right, Andres. I think what I'm going to say challenges us as the WHO, but also, you know, the panelists can help us think this through. You know, the pandemic of NCDs, you know, for lack of a better description, has been with us for a while now. It really has. I think we know now that, you know, the old thinking, you know, that diseases of lifestyle were only present in developed countries and high income countries is no longer true. It doesn't hold true. Obesity in developing countries has gone up childhood obesity, and all of these things that usually were not the bread and butter of healthcare ministries or ministries of health in those countries, has now been what is confronting governments in those countries. Unfortunately, you had a dual challenge in that the same countries were facing the big challenge of communicable diseases. But we could say we're not done yet with the fight against communicable diseases. But the NCD tsunami, we call it, which is really like a pandemic, is going to be right in front of us immediately after this. I think one of my panelists mentioned it by saying, the morbidity that's going to be the outcome of this pandemic is going to be huge. So I think indeed we should use this, because if we don't, the burden of disease on the health system is going to really crush us. So this is one of the things that I think we should advocate for very strongly, but also continue to refine and nuance these investment cases. I think we make a mistake with the way we present them. I don't know how often beyond the meetings of the G20 and the ministers of health and finance and other fora that are really at the high level, do we ever have these intergovernmental or cross-governmental department conversations between ministries of health, finance, energy, all of these things, because the risk factors we know, but we seem to be completely paralyzed by our ability to speak to the food industry, for instance. We as WHO have constraints, as you know, everybody has constraints, but we live on the same planet. So the question, that I'm posing to my panel members is, how should we as WHO, with the data, we've got the data to show countries that they are facing an NCD challenge. How do we get this data to be accepted and acted on? We can produce as much guidance as we can, but how do we make this a bottom-up approach, a demand-driven approach? And it's not easy because, people like to eat what they like to eat. They don't exercise, even if they think they need to. So these are different things. What skill sets are missing? Behavioral economists, who should we be calling on to help us translate this knowledge into a policy brief or beyond that gets other people involved, engaged, and shows the impact of NCDs long-term on the health system. I've always been, fascinated by what happens in my country. I come from South Africa. Every time there's a holiday season, and the Ministry of Transport counts the number of fatalities or fatalities, and it's the Minister of Transport who speaks to the populace about don't drink, don't drive. But I never see the Minister of Health showing the counter, showing the beds that are now occupied by all the people who've been injured in these road traffic accidents due to alcohol. They don't come together. So it never really clicks in the mind of a consumer or a citizen that, if we do this, choose this behavior, this is what it's costing us in tax money or something like that. So there's somewhere where we are not communicating to policymakers in a language they understand. And I really hope that we can get some bright, shining lights on this panel who can help, because we are not short of data. We're drowning in it, but we are not using it. Over.
So who would like to come in? Shannon, please.
How can I not after Nono's great sort of call to action? And I think, just sort of building on what are the investment cases that might be needed. And I would build on that with an even more global one at this moment in time, which is I'm actually hearing a lot in Geneva and elsewhere, this almost de facto assumption that because of the economic challenges caused by COVID, we should just expect every country all over the world is going to spend less on health going forward. And I feel like we have to challenge first, like we've just had the biggest example. We're in the middle of the biggest example there is, that failure to invest in health causes a lot of economic pain. And so I think very first, even before we get to the more targeted investment cases, we have to counter the idea that now's the time to save money on health as soon as we get out of COVID, and say, no, now's the time to make sure we don't spend extra on health next time. And that includes, NCDs and pandemics. And I think that sort of leads me into, and it might be an echo of things I've already said, but, I really like to see not pandemics versus NCDs, but how are we using lessons learned from either, to push forward? And I think in this case, what are the elements that have come out so strongly from HIV, from COVID, that matter to a different kind of system for health, and one that will address NCDs. You've heard me say some of this. Number one, for community resiliency and resilient health systems, community-led infrastructure that puts community members in decision seats, in service delivery seats, in monitoring seats, has to be considered part and parcel and funded as part and parcel of that cohesive system of health. It can't be an afterthought. We can't build a structural system first and then do a little around the edges with community. Otherwise, we won't get to the demand that Nono is talking about. We just won't change how we prioritize and how we problem solve. Second, this example of differentiated services, those that do more to enable self-care or do more about bringing services to people instead of people to services, again, shouldn't be an afterthought. Yes, you will always get, for any program, whether it's a hypertension screening or an HIV screening, you will get a certain amount of the population who will show up, no matter how hard it is to show up, and will fight for those services. But there's a lot of people who never will, and you'll never get that way. So rather than our preaching, well, you should just access services this way, now's the time to say we got to change the way services are accessible if we want to meet people's needs. And I think this is very true for women, that services can really be agile and responsive to the needs that women have. And I think a couple of things that we're just seeing in COVID that are true across the board, we can see we're very far from done with gender responsive budgeting and financing and digital inclusion and, disaster risk reduction or infrastructure. Beijing Plus 25 report showed us where we failed to make progress or sufficient progress since Beijing. And we are doing better in the short term on some of these issues, but not all. So can we accelerate not just recovery from COVID by doing better, but build that into all sorts of NCDs and pandemics, period. And then also that any health issue, be it a pandemic or an NCD, yeah, it's about health, but it's also about more than health. And this is building into what Nomo said about how do we get other sectors joined up? How do we recognize that, we have to meet certain basic needs alongside the health needs to really have people in the best health possible, resilient, ready to access service, ready to respond to the next challenge. So how do we get people to do all that?
We can get, Anya, thanks for raising your hand. How we can get an agenda lens on that future game change?
Thank you. Yeah, and two brilliant interventions, and I think all the right spots already said. I wanted to pick up on one thing that I think we're all encountering, which is on the one hand side, the risk of now really important programs falling off the agenda. We were touching on family planning and MNCH programs, but of course also, as you were mentioning, all the non-communicable diseases. This is the worst that could happen. And I remember this is probably 5-6 years ago, the Lancet Commission launching an investment case for health, which made a very, very good and sound case as to, you know, why investments in health are actually the best investments that an economy can make. And you are entering a virtuous cycle of resilience and growth, and ultimately, you know, sound and wealthy societies and economies if you are putting the right policy and frameworks in place at the same time. One of the things that that strikes me, and I think Princess Simelela was also touching on that, is the silos in which these conversations are always taking place. And we have, as a foundation, always struggled with, you know, how do you get to the right level of the decision makers, and how do you avoid these conversations taking place in silos? I think one of the most encouraging signs that we saw last year is when the finance ministers of the AU actually took up family planning as something that they need to incorporate into national plans, because there is a economic case, you know, a very obvious one. And I think we have, as we're all agreeing, a huge amount of importance, which now is really placed on data, making data accessible, understandable, transparent, and really make sure that there is sufficient advocacy also in order to make sure that this data that we now have, on the one hand side with the gender lens disaggregated, but also with the implication and the economic implications of the COVID crisis, which everyone and every person is globally feeling. I think we were never in a situation where we have high income countries and low income countries being affected in such a similar way. So I think we have a unique opportunity in a way to now really try to break down the silos between these conversations and make sure that the finance ministers, decision makers, are equally exposed to the economic consequences of a health crisis, and the economic consequences of gender inequalities. And I think this is in many respects an opportunity. How do we make sure that this is being heard? I think communication, good digital tools and communication tools really play a very important role. And I think now in the digital age, they may play going forward even more an important role than, you know, the traditional G20 gatherings that we see that also often, you know, end up in a communique that everyone is proud that it finally got signed. But I do think we should not underestimate the opportunities that the technology will bring us going forward, to really make sure that this data turned into the right policy messages that cuts across the different silos can be really dispersed into with the help of social media in a much more effective way than before.
And just to pile on that, I mean, in the same way that we are sort of all in the same boat with COVID-19 right now, we're all going to be part of that same NCD tidal wave that's going to happen afterwards. This isn't going to be a problem of one type of health system or another. It's going to be all of our problems going forward. And so how can we continue to leverage that? How can we continue to leverage that sameness that we're all going to have? But I would just like to sort of double down on something that Shannon said earlier, which is that these are global problems with community solutions. And, you know, I think the ability for us to actually find in places around the world, and I think the City Cancer Challenge does this beautifully, you know, local hospitals, local communities where you can actually get in there and understand what are the root causes, what are the real issues that prevent people from seeking care, from getting the right kind of care. And you can bring that whole community of care together to try and make a difference. Those pilots are understandable, they're replicable, and sometimes the problems that you're solving actually aren't the really big ones. The really meaningful ones sometimes are much smaller. And so I'd love to see more of those opportunities for us to collaborate across our silos and to think about how can we go into some of those communities and make really meaningful, impactful change, and then use that to radiate out what's possible. Because there's some really amazing things happening out there on the ground. We need to get them to the same level of understanding as we have as our big macro problems.
do we need, I think you address really the key issues. However, how can we, do you think we need a new platform of interagency and organizational collaboration? Do we need another global fund, or what is your views in the future to institutionalize the dialogue? Because from my experience, the institutional boundaries are enormous. And how can we have a need-based, stable cooperation where we have roles and responsibilities shared, and with a gender, or let's say a woman health gender on that? Would love, somebody would like to come in on this, on that question?
Andreas?
Please, yes.
Yes. Oh,
Yes,
thanks.
please.
Can I just repeat what you've said so I can be clear about what are the two
In order to
points?
institutionalize, what we are doing now is spontaneous. No, we have an emergency, we work together, and we bring all the people, all stakeholders. But to have a long-term effect, we need a new platform of cooperation, UN, foundations, private sector, civil society. Do you think we need another broader global fund, or UNAIDS is already an interagency platform? Do we need something broader?
Well, I think your indirect question is about whether the multilateral system needs to get bigger with more players, or whether we need, I think when we are maybe frustrated by one issue, say I won't pick any agency, but just an example of something that we've all agreed at the global level and we want it done at the local level. I think the frustration with vertical approaches is understood, but it could only be understood in the context of where the responses came from. It's not, when the Global Fund was put in place, there was nothing. There really was nothing at that point. And what I will call out, which is a worry for myself, is that in the time that the Global Fund has been active, we didn't, on the side of developing countries and so-called recipients, maybe build enough capacity or capability to do the things that the Global Fund does better. Firstly, to be able to do what they do. And if you contrast that with the innovative financing mechanisms that Gavi brings, so each of these agencies had a strength which maybe national governments could not replicate, and therefore they became necessary. So I would say with COVID now, in the way that it is, it's not the time really to pull apart what is existing, because it's the very same institutions now that are in the Act A accelerator, that are here, that are there, that are helping countries. So to unbundle them is going to be a big challenge. I mean, the SDG gap is trying to get them to work better together. I think that effort needs to push through from the top to the real bottom, which is where it matters anyway. But right now, I think what we should also be thinking about is these innovative financing mechanisms. Some of them are loans to countries. So countries need to start quantifying how much debt they are acquiring right now by way of all this money that is being provided by the IMF, the World Bank, and others, and see what that means to their own fiscal outlooks. And it's difficult, I think, because the whole world is in a recession. So it's not easy. But building back better for me at the national level, because I think we also create this divide that says, oh, we are here in Geneva, in New York, somewhere else, we're going to find a way to assist somebody out there in another country, developing country, whoever, to build back better. But everybody has to build back better. So it must be those in the country that define what is better for them. Those are the people that need to be saying to us, this is how we think better looks for us. So we don't come with a one size fits all. And if better for a handful of countries means having joint funding with another organization or institution, so be it. But remember, these institutions took a while to build up and to get to where they are. What can we learn from them rather than expanding them to be bigger and bigger? What are the lessons or the gems of success, which I believe is what the SDG gap should do, in addition to making them work better, is to say, okay, what are the key lessons that have come out? Why is it that Gavi is able to get vaccines even into a country that's got absolutely no supply chain? How do they do that? And then the nationals sit and learn, and the ministries fund that skills transfer and not constantly rely on, oh, somebody from Gavi is going to come in and fix the pipeline of vaccines for us. That's what we should do, that we are not doing deliberately and so strategically. And that is a conversation that should happen at the national level about how you institutionalize capacity at country level, so that you are not constantly calling on experts to come and save the citizens. You know, so that's and it goes to the heart of the work that you do, Jalit. I was asking someone yesterday, we were just talking about all of this. What has changed or needs to change in how we train undergraduates and postgraduates in medical schools to cope with this kind of reality? Our approach is archaic. You know, we still teach medical students only in the medical school. They never visit industry. Why don't we take them to Roche and help them see how the drugs are done? You know, like we put them in the lecture hall and they go nowhere except to the bedside when they're ready for clinical training. And then off we chase them into the world. They are completely underprepared for the social and the economic issues that surround them. So that's another change, I think, that should be part of the building back better. And let me stop here and give others a chance. Thank you.
Thank you very much, Nono, for this very wise vision, not to change the game at this institutional level, but to bring it to the country leadership and ownership. And now I would like to hand over to Jalit to bringing also, we have some questions from the audience and some burning questions, and Jalit will bring them to the panel.
Yes, so there are many questions from the audience, and there's one topic focusing on social workers, because we know that especially women are so active in engagements of all the initiatives, but generally they are not really structured, they are not supervised, and even not paid. So the question to the panel is how we can use them to support all the initiatives to increase the women's health care, and how we can bring really a sustainable structure into the system. Because if we are really honest, without this engagement, we are not really possible to survive. So the question maybe to you, Shannon, how we can use this wonderful resources, but not as a nice to have, to use it as a critical point of our care system.
Yeah, maybe I think both overall, but also in here and now. And I just want to say, as UNAIDS, I think we have a very strong principle that people should be paid for their work. Nice to have volunteers every once in a while and to mobilize in a crisis, but the reality is oftentimes the folks that you don't want to pay for their work are women. It's disproportionate there. And when we cost out certain models, like we've been working with Africa CDC and some others to say, even for COVID, how do we mobilize some lay workers, community-led workers to be COVID extension teams, community-led teams that have to do with information or disinformation combating, or, you know, tracking and tracing and testing. And, you know, when we really mocked up the packages of both what could people do and what the costs were, one of the main costs was simply providing adequate PPE during COVID, giving people the materials to keep themselves safe during COVID. And interestingly enough, I think Global Fund is finding that they are not seeing nearly as much expenditures on PPEs out of the monies they've made available as would have been predicted. And when we're on the ground, we see frontline people can't access wherever the big old stores of PPEs are. So one is giving people not just the tools of the trade, but tools of their own protection. And that would mean for social workers and other, you know, paraprofessional and professional and lay cadres, that whole risk, but people who are out in the front line. Second, the salaries are not huge. And being able to institute that reliability, that sort of connection to the work is very, very important, I think. And so I think it all has to be recognized as essential. And part of the ways we recognize things as essential is by paying people for their job and giving them the tools to stay safe and doing their job and understand, you know, letting them have the tools to draw the picture of what they're accomplishing by delivering on their job. How much better off people are when they're part of the team than when it's done in isolation. So I think very much agree with the promotion by the questioner. Like, what are we thinking if we're not paying for this? And I think even though it's not the topic for today, this also has a corollary in what we're not seeing delivered all the time for mental health services. And not just mental health services for the extremely mentally ill, but also some of the peer and social worker-led interventions for mild to moderate depression, anxiety, other issues that can really help. And I think we've seen plenty of evidence that, including social workers and lay cadres both, in some of that chronic mental health work can be transformational for clients and is oftentimes not included in what we map out as essential.
Thank you. Andreas, maybe you give the next question to the audience.
There's a question about how we can bring in the expertise of academia, of university, our institution, for example. How can academia play a role in best practices, in education, in bringing the universities, in bringing a worldwide network of academia into the discussion, into the service delivery, to bring it there where it's mostly needed. This is the question. Who would like to probably Jalit will
only a short
answer on that? Yeah,
and maybe only a short answer, because I think what we have seen now in the pandemic is that even we, as a big institution, all they have limited resources. So the question is, what are my core elements in education, training, increasing awareness, and even taking care of my women with their diseases? So what we already addressed, education, training, but even to give access to women to healthcare services. So what we can think is, why only to focus on medical students? If we have to train the medical students, the young doctors and nurses, why not take a specific limit even to other professions, and even to open the door as a region to increase the awareness? Because what medical academics generally not be trained is in interprofessional communication and work. And that's the reason maybe we can give a commitment to find these silos even in one university. And you know, we're always surprised what the neighbor is doing, because what we generally discussed to bring an umbrella being the governments, we have to start with our immediately closest neighborhood. And again, let's open the academic places to all professions who are dedicated to women care. That's only a commitment, but I think we can change the world by starting with small steps.
Thank you very much, Jalit. And now I would like to open the final round. We have a couple of minutes, and please, Dr. Simelina, would you like to start a final statement from your side, from WHO, and then we go around?
Oh no, there are lots to be said, but I think today was very, very exciting and I think challenging in thinking about things we should do differently. I pray that we don't go back to the old ways of working, but that we really find a way to bring just this big spirit of collaboration that we've seen at the global level through Act A and many other initiatives, right down to the regional and local level, so that there's true preparedness for what surely is going to be another pandemic, and we can see that. And I just want to thank you and Jalit for this opportunity, and just to say thanks a lot as well to my panelists. You've gave me a lot of things to think about as well. Thank you.
Okay, thank you so much. Shannon, would you like to come in with some statement for the eternity now?
Sure. Well, I think this is a time, and as we go forward, it will be a time where history will judge us not on how the collective we serve those that are easiest to reach, but whether or not we effectively serve those that are much harder to reach. To do that, we have to attend to services that fit people, not people that fit services, the multi-sectorality, the social enablers. To do that, we have to complement services with decriminalization of people or behaviors that unfairly target individuals and populations, and again, make them harder and harder to reach for the health needs they have. We have to embrace the idea that there is no trade-off in a pandemic or a non-pandemic between a public health response and a rights-based response. In fact, the only effective public health response we will see is one that is based on human rights, so that it can not marginalize and distance people, but serve and bring them in to be part of a public health effectiveness response, family wellness kind of model. So I guess history will judge us. We didn't get it right for HIV in the beginning. We still didn't get it right the second time with COVID. So let's just get it right for the long haul as we go forward and keep building on that. Let's not wait for the next pandemic to convince us we didn't get it right again.
Get it for women's health, and now for Anja to give a statement. What is the future of your vision for the future for global women's health? Lessons learned.
Thank you.
Over to
Thanks.
you.
No, and thanks to all the panelists. I think this was really a very interesting and very enlightening discussion. I mean, I think we had at the beginning already felt that there's huge alignment with regards to our situational analysis and also our assessment of the effective interventions. And I think that is a good sign, and that's an encouraging sign, because at least we are seeing the opportunities and the challenges, no matter from whatever angle we're coming, really through the same lens. And that is something that we should, build on, because this is a positive energy that we should harness. And I think we have the same assessment. Building on what Shannon said, I think the most important thing for us to walk away with is that we are not ending up in a situation where high-income countries and high-income countries get tools, access to medical tools first, where we are neglecting the poorer countries and where we're not making sure that we have equitable access to the different tools and long-term solutions that we're developing. This runs incredibly much, even more true for women. We cannot allow this situation again to end up in one where we see progress that we have been made on women's rights and improvements to go back and throw us back another 25, 50 years. That would be really a terrible outcome. So I think we have to work really hard on that. For that, we do need to fund the resources and the multilateral responses and tools that we have put in place. I think Act A is the best response that we can at this point in time build on, and that builds on the incredibly good track record on the multilateral organizations that we know, on Gavi, on CEPI, on the Global Fund, under the guidance of the WHO. That's what we need to leverage and harness now and really work on it to make sure that we are, and that is my third call, to the audience. The one thing that we of course need to keep building as a cross-cutting tool are health systems. And we have made the link to the economic downturn. We have made the link to everything. It is at the very beginning and at the very end of any, functioning economy and society. So that would be my 3 calls to action.
Thank you very much for this great statement, very precise and to the point. And Theresa, what is the future of the private sector coming in doing global health with the focus and the angle of women? What's your statement?
Wouldn't be 2020 if you weren't on mute at least once in a meeting. So again, a big thank you to the co-chair, big thank you to my panelists, great conversation. I would say traditional approaches are going to give us traditional solutions. And I think we can say our traditional solutions have maybe not been as effective as they ought to be. So I would love for us to learn the lessons around innovation, digital health technology, and partnership that we've started with COVID and be able to extend that to NCDs and particularly cancer and particularly women's cancer as we go forward. But I think what is going to make the difference going forward is not more in different structures. It's a different kind of communication and a different level of trust between the pieces of, between all of us who hold the pieces to make this look different in the future. And I'm looking forward to some great collaboration in ways that are really important and that will ultimately make a difference. So thank you for this opportunity.
Thank you very much. From my side, Jalit, final word.
So again, wonderful.
Charity, hosting.
Sorry, I'm really proud to be part of this, and I'm even proud that we already committed that we have a follow-up meeting, because not only dialogue, at the end of the day, we want to bring something special to the next level. And I'm really impressed by the panelists that we underline that women are the acceptor, the donator, and the protector of healthcare at all. And I think that should be reason enough that we make the next steps to preserve and to increase our initiative. Thank you very much to all of you. And Andreas, you have the final words.
I also would like to thank the teams, because it's not only the speakers, but they have worked with a team around them to prepare for that. And I'm really very happy that we are all together now with this perspective of not only having a panel, but also have a communication between these organizations, which normally I think don't talk too much on the day-to-day basis, in particular on the World Health Summit. Thank you very much. And I can't say travel safe back to where you are, but because you are where you are, and hopefully next year we will meet in Berlin again. Bye-bye.
Bye.
Thank you to all of you.
Thank you.
Thank you. Bye-bye.
Thanks, Jarit. Bye.
Thank you, Princess. Thank you.